Hello, hi, this is Elliot Fishman, and welcome to our Facebook Live. And this is going to be on CTA of the extremities. Hope everyone's having a great day. I think to be having, we're on live, so it's good. And I'm just trying to adjust my thing here. So hope everyone's doing well. One of the things we try to do on many of these Facebook Lives is to try to cover different topics. And I think I mentioned that the third Thursday of every month we do a quiz. So we have been doing the quiz, and we discuss cases that I typically present at my own conference every week. So that works out pretty well. And then the other times we try to discuss topics of interest. And so one of the topic of interest would be CTA of the extremities. And people have asked me if we could speak about that. So that'll go very well. Now, I will say that you can ask any questions you want or make any comments, and I'll try to address them as we go through this. So let me get started. We do lots of CTA of the extremities, and what I'll try to focus on mainly will be the lower extremities. So there's certain things, and so let's talk about applications of the extremities CTA. So one of the biggest applications is in trauma, right? We do lots of trauma patients, gunshot wounds, stab wounds, MVAs, and often you might do CT to look for bony injury. That's a classic example. But also you want to look at vascular injury. One of the reasons CT is so good is you can do the bone and the vessels at the same time. No need for taking someone to angio. CT is very good at defining normal anatomy, very good at defining vascular injury, whether it's an active bleed, whether it's spasm, whether it's dissection. Whatever the process relates to the vessels, we can see that very well, and we can see it in relationship to any potential bony injury. We also can look very nicely at the muscle and soft tissue, so a very comprehensive examination. The key, of course, for the lower extremities, or like all CT, is protocols. So the question you then ask is, what's the best protocol? How do I do this best? So that's a good question. Now, typically we do arterial phase. Every once in a while we'll come back and do venous phase. But if you're thinking about arterial phase, sometimes with the trauma studies, you're doing a pan scan, right? You're doing a scan from the neck down through the lower extremities. In that situation, you're typically arterial phase, but by the time you reach the pelvis and lower extremities, arterial phase with good flow and opacification. I think the challenge of the extremities, and let's take an example now where we're not doing the whole abdomen and chest, but we're starting from the crest perhaps and going downward. The challenge always is, how do you get a study that is not too early and is not too late? If you're too early, then you may not see flow beneath the let's say popliteal artery, and you in fact can make the mistake of saying the patient has lack of flow where it's simply too early in terms of timing. If you wait too long, then you're going to get a lot of venous contamination, as well as when you look at the trifurcation vessels, the opacification is going to be less than optimal. So it's a balancing act getting the right time. One of the things we try to do is triggering based on attenuation, based on location. So if you're going to do from the crest down, if you put a point in the aorta, and let's say you have a fast scanner, remember, depending how fast your scanner is how fast you can scan through the extremity. The faster that your scanner, the more you want to wait. If your scanner is slow, you'll probably trigger earlier. But if you have a 128 or better, even better than 64, you probably will trigger at about 25 to 30 seconds at the aortic bifurcation. That's kind of a good triggering point. And then you'll scan downward. Now, one of the things we tell the techs, particularly when the calf vessels are very important, is you need to be very careful, because even with the best timing, there's a variation in flow. Older people have slower flow to the lower extremities, so it is a little bit harder. Okay, so that's something that you need to be aware of. And so again, I don't want to falsely say this patient has no flow to the lower extremity or has decreased flow when it's simply just a timing issue. So the way to get around it is and also you may have better flow to the left leg than the right leg. So you can make all sorts of errors. To me, the easiest thing to do is when I'm doing these studies where you need the runoffs really well and the timing thing can be so variable, is after the first run, go back and do a second run. You don't need to go to the crest because typically the SFA popliteals are all going to be well opacified. I'll go a little bit above the knee at the second run, so I'm getting some of the popliteal, and then I'll go for the trifurcation vessels. That's the easiest way of doing it. I think there's no magic. You're not going to make any mistakes. There's low radiation dose. It's far away from, it's in the periphery of the body. It's not going to be a problem. I think that's the best thing to do. Now, in terms of protocols, I like to inject 5 cc's per second. If you're going to do runoffs, you need good vessels. I need 100 to 120 cc's of contrast. Remember, you can get by with less contrast if you're going to dual energy. That can work very well in that regard, doing both high and low kV. Dual energy is ideal for doing runoff studies because we can subtract bone. One of the most important things in looking at the vessels of the lower extremity is to remove the bone. Now, at the femur level, it's not very hard to get the SFA and popliteal, but the trifurcation vessels are difficult, particularly in patients who are older, who have lots of vascular calcification. A challenge, dual energy tends to be better at removing bone because it removes less non-bone. Often with classic technique for removing the vasculature, you also remove a lot of other structure. You remove the bone and then you take away a lot of vessels for no reason. Particularly when there's lots of calcification. Now, I know the vessel may have a lot of calcification, but there still may be flow in the vessel. The computer algorithms at times tend to recognize the calcification as bone and take everything away. And then if you look at the edited images, you can swear the patient has no flow. So to me, the biggest danger is not making mistakes saying there's flow when there isn't. It's saying there is no flow when there actually is flow that is present. So I think that's a superb technique to use. So fast injection, I like to go 5 cc's. Good timing, again, trigger. If patients are older and they look like they have a big heart and cardiac output is poor, wait a little bit longer. And then, since it's hard to be perfect, get a second run from above the knee by the popliteal down through the lower extremities. Again, bone removal is critical. We tell our techs to always do bone removal, and dual energy makes bone removal so much easier. Now, in terms of applications, I mentioned trauma, and trauma is the big dog in looking at peripheral vascular involvement, right? We mentioned gunshots, stab wounds, and that's going to be true with the upper extremities as well. I think CT is very good looking from the axillary artery to the brachial artery, the brachial to the radial and ulnar. We're good looking vessel patency, spasm, dissection, active bleeding. CT is very good upper and lower extremities for active bleeding. Now, obviously from a protocol question, when you scan the lower extremities, the patient's legs are extended. When you scan the upper extremities, depending on how the patient is, you might need to scan arms by the side or arms over the head. Arms over the head is probably better in most cases because you can kind of open up the vessels in the axilla. The problem is, and that works well, of course, if you're doing a chest at the same time, you can just scan upward. There is a challenge, however. Some patients, you need to have the arms by the side. They can't keep their arms extended. The challenge with arms by the side, often there's a little bit of compression in the axilla. Also, there's a lot of artifact at times, but that can be done well also. I think it's a challenge. The biggest thing is have the patient not move. If patients are uncomfortable and their arms are over their head and they're fidgeting during the study, you have lots of artifact, it's not going to work very well. So that's one helpful thing. And again, with the upper extremity, what I'll try to do is if I'm worrying about a right-sided injury, I'll inject on the left side. If you inject on the same side as the process, particularly with the arm by the side, even arm over the head, you get a significant amount of beam hardening artifact from the contrast coming in. If you do it on the contralateral side, then you don't have that same artifact. You may need to wait a touch longer to get good flow, but it really works out very well. So that works out very nicely. Okay, what else? So let's go back to lower extremity. Sometimes we are doing, the patients are getting fibular flaps. So patients have tumor of the mandible or infection or some reason they need to do reconstruction of the mandible or around the face, any of the facial areas. And so they need to harvest the fibula. So we will do a free flap study. That means a study above the knee, down through the ankle. We'll look at the vessel flow. We'll look at the trifurcation and the popliteal artery and make sure which is the best one to get. Make sure there's good blood flow. Make sure the anatomy is going to be correct or what variable anatomy there is. So that works out pretty nicely. So we do lots of free flaps. We also do some tumors, right? Because people sometimes have tumors and you'll look at the vascularity of tumors. So patients with soft tissue tumors like sarcomas, obviously MR is typically the study of choice, so that works out pretty well. And that's kind of a good way of doing it. I think that's a good way. What else? Other applications, we said trauma, we said preoperative planning like a fibular flap, we said tumors. At the end of the day, probably the most common study we do will be for atherosclerotic disease, peripheral vascular disease, peripheral arterial disease, PAD, PVD, depending how you want to abbreviate things. And so the question is, the surgeon wants to know, how do the vessels look? Is there occlusion? Now we also do see a lot of patients where they've done procedures. They may have put a stent in. They may have done a bypass graft anywhere from an axillary fem to a fem popliteal or fem perineal. So one of the things we look at also is patients who are post-op. Is the surgery successful? Is the flow good to the lower extremity? We do that as well, and that seems to work out fairly nicely. Biggest challenge with peripheral vascular disease is patients with really extensive calcification. One thing I do very carefully is I scroll very slowly through the axial images, because often you'll see flow, 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 no flow, flow, no flow, flow, flow. When you're looking at a MIP or even volume rendering, even coronal, it's sometimes hard to see that because of the extensive calcification. So you need to be really careful in that regard, but that becomes very important as well. So I think I try to look at that. I look very carefully at that. So you want to look for small areas of narrowing. Again, a challenge for us still is calcification. Always this idea about dual energy CT with bone removal. With the spread now, remember the first spread was like 8130 in KVP, then 8140, and now 80 or 70 rather in 150. The bigger the spread, the better you are at removing the calcium and contrast. But again, it's a challenge when you have very minimal flow. If you're relying on the images, you're going to overcall the presence of occlusion, because when you have so much calcification and you have minimal flow, it's going to be somewhat problematic in that regard. So it's something to be aware of, it's something to be careful about. Now, so I do we do lots of peripheral vascular disease, again, grafting and stenting. One of the things with peripheral vascular disease, you need to be careful. The patients are older, and so those are the patients also who probably are going to have a harder time with timing, because often their flow is slow. And again, you don't want to be calling things that are not there but are simply flow related. So that becomes very important. I am looking now at questions. I don't really see any questions now. I have to admit, Facebook has really, as Facebook always does, has changed what I'm seeing. So my screen, which typically had two different things only, I have a whole bunch of things going on here. So it's a very tricky thing from what I'm seeing. I don't see, I'm looking at insights. I don't really see any insights yet, but we are live, so we probably don't see insights after. I do see Alberto from Oklahoma. Hello, Oklahoma. Yep, there he is. Thank you for a very helpful topic. Thank you, Alberto. And Alberto's the only one I see. I guess everybody else is slacking off today. One thing to tell you a little bit, just so if you look at CTisus, the website, on the teaching file, there are a lot of good runoff cases there. We also have a few lectures about runoff studies, so that can be very helpful as well. And if any questions, just let me know. Also, to let everyone know, we posted a lecture that Doug Becker on entrepreneurship was a couple weeks ago at Hopkins for our special series. That's now live on Facebook. It's live on um, YouTube, and it's going to be in the front page of the website. I think Sarah's going to put it up today or something like that. So it's an hour and 15 minutes, so it's a long talk. It's about a 50-minute talk and 25-minute Q&A, but it's well worth your time. Then we see Liliana. So Liliana's been sending me some incredible pictures from the West Coast. Liliana survived, I guess, the J&J vaccine. And hi, Liliana. And Liliana's out in Palo Alto. I think both Liliana as well as a good friend of mine, Mike Federley, they always send me pictures. When you're living in San Francisco area or Palo Alto, you know, the water is nearby, the mountains are nearby. You can take all sorts of pictures. It makes the world seem perfect. In Baltimore, all I can take pictures is from my way home. Today was a big day for me. I got gas in the morning, so I stopped somewhere. Okay, a question, does the type of IV contrast play a role? I mean, the main thing is you don't want the patient squiggling around. Depending on the patient's creatinine BUN, we either use Visipake 320 or Omnipaque 350. So those work very well. I think those are two both really good contrast agents. Beyond that, I don't have any experience, but those two work really, really well. So you can look at it there. Let's see what else. Any other questions? Oh, there's Lily just posted runoff studies, so it's in the teaching file, so you can see them there. We have a lot of cases there, and it's also in some lectures. I think there's a lecture on peripheral vascular disease specifically, that we have it there, but there's a lot of cases online that I think you can look at. And I am working on another talk, so maybe I'll work on it. When I finish that talk, I'll do something with peripheral vascular disease. So I think that's about all I have for this morning. There's no other questions. I'll let everybody go, and I hope you have a nice day. I have to ask Liliana. Liliana, what do you think of my beard? I guess I never had a beard, but because of COVID, you're wearing a mask, no one could tell. So I decided to grow a beard. I don't know how long it's going to last, but it'll last forever because it'll be on YouTube. But anyway, okay with that. Have a great day, and I'll see you later.